Hello everyone. Today we are going to talk about asthma. So by definition, asthma is an airflow obstructive disease. Now it refers to that it's an airflow disease, that is the problem lies within the airways and not with the breathing technology down below, that is the alveoli. Furthermore, it is a reversible disease, that is the acute attacks they can be made reversible. The problems with the airways, we can reverse them. Now, what exactly is the problem with these airways? There is always a chronic airway inflammation, which ultimately leads to airflow hyperreactivity to minor triggers and ultimately causing obstruction, causing the symptoms like wheezing, shortness of breath, and dyspnea. Now, this airway inflammation, it is because of the genetic factors, and this airway hyperreactivity, it is because of the environmental factors, and both of these factors, genetic plus environmental, ultimately lead to airway obstruction. Coming on to a bit detail of the airway inflammation, there can be three different types. It can be predominant airway eosinophilia, it can be predominant neutrophils, and it can be polygranulocytic response in which there are no neutrophils. Now, why we are discussing these? Because polygranulocytic type of asthma, they are very less responsive to the steroid treatment. And this airway inflammation, which is because of the genetic factors, it is responsible for the baseline symptoms like cough, runny nose, cold, and recurrent chest infections that these patients suffer from. Ultimately, when they have been exposed to some allergen, their airway, it reacts, and it reacts in two phases. Early phase, which is due to the release of preformed cytokines, and then there is a late phase, which is because of the inflammatory cells. And these inflammatory cells can be eosinophils or neutrophils. Now, what will happen when how does this airway react? The smooth muscles, they will contract, mucus will be released, and the lumen, it will get narrow. And this airway hyperreactivity is responsible for the acute attacks. Now, this acute attack, it is characterized by the wheezing, shortness of breath, chest tightness, and coughing. Now, the various triggers which cause the airway hyperreactivity, they are listed down below. They can be allergens like pollen and dust. It can be bronchial infection and betel nuts, cold air, drugs, emotional upset, food, GERD, hormones, irritants like smoke and perfume, and job related like wood dust, flour dust, and animals. Why should we know these triggers? Because we have to ask about their exposure during our history. So always ask about the occupation, smoking status, drugs, past medical conditions while taking the history from these asthmatic patients. Also, if there is a known trigger which is unavoidable, like exercise, like this cold air, so what we can do is to give them prophylactic agents before the exposure to these unavoidable agents. We will talk about the asthma drugs and how do we give them in the next video. So till now we have talked about what is asthma, what is the pathogenesis of asthma, what type of cells are present, what are the various common symptoms, what are the various common triggers which provoke asthma. Now coming on to what investigations we can do and how are we going to diagnose asthma. So the various investigations, the gold standard is spirometry, but the most commonly used in clinical settings is peak expiratory flow meter. Then we can also do some airway hyperreactivity challenge tests, particularly like if the trigger is like exercise. Then there are simple allergic tests for other types of triggers, skin pricks, total and allergen specific IgE, and we can also do the peripheral blood eosinophilias. We can do chest x-rays to see the hyperinflation, and we can do the EBGs and pulse oximetry in the acute asthma cases. Now, this is the diagnostic criteria of asthma, which every student should know. If FEV1 it increases by 15% after giving bronchodilator or steroid, it is a diagnostic criteria of asthma. If FEV1 decreases by 15%, after doing the 6 minutes of exercise, again it diagnoses asthma. If FEV1 shows more than 20% of diurnal variation or more than 3 days a week for 2 weeks, it is diagnostic of asthma. So I'm just covering a basic of the asthma drugs here, and I will make another video for the detailed assessment and grading of the basic asthma and the asthma attacks and how do we treat them, how do we manage them in the next video. Here is just an outline of the various asthma drugs. We basically classify these drugs in three categories, namely relievers, preventers, and prophylactic agents. These can be beta-2 agonists, theophyllines, and omalizumabs. So relievers are basically those drugs which are given in the acute attacks to relieve the patient's symptoms of wheeze and shortness of breath. These preventers, these are to combat the chronic airway inflammation, which can be steroids, cromolins, and leukotriene antagonists. And ultimately, these prophylactic agents, these are given before getting exposed to an unavoidable trigger like exercise. So before an asthmatic patient goes for the exercise, we can give them these agents and we will further talk about them. Now coming on to the beta-2 agonists, these can be short acting and long acting. By short acting, we mean that their effect starts immediately within 1 to 2 minutes after giving them, and they reach their peak effect within 10 to 20 minutes. So these are very effective for the acute asthma attacks. Now short-acting drugs, they include salbutamol and terbutaline. And the long-acting drugs, these include salmeterol, formoterol, and vilanterol. Now omalizumab, it's a new kind of reliever, which is basically an anti-IgE agent. It is given subcutaneously only for moderate to severe allergic asthma, and it is used in more than 12 years of age. Now, steroids. Steroids are wonderful drugs, and we have always learned that whenever there is inflammation, we give steroids. But amazing thing in asthma is that oral steroids, they are used mainly for the exacerbations because they have huge systemic side effects. So we only give oral corticosteroids during the exacerbations, during the acute attacks. And these inhalational corticosteroids, they are used for the prevention. And their dose range, we keep them less than 1000 micrograms in adults, and our target is to keep the dose less than 500 microgram in children, because at more than this dose it causes adrenal suppression and growth suppression, and that is why inhalational corticosteroids are not a preferable preventer in pediatric age group. We prefer other types of preventers in pediatric age group rather than giving them these inhalational corticosteroids. So coming on to the preventer for kids, we can give them montelukast, sodium chromoglycate, or nidocromil. We normally give these preventers for 4 weeks, but if they don't act, if there is no response, we ultimately have to use the inhalational corticosteroids, but our aim is to keep the dosage less than 500 microgram, or else there will be growth suppression and adrenal suppression. So here are given the names of the commonly available inhalers in the market and what is their composition. You can have a look on these. Thank you so much for watching this video, and if you have any questions, please drop them in the comment section. Thank you.